All right. It seems that we're running slightly ahead of schedule, which is good. So we'll just keep going. We'll make a break. At what 10:30, I think it's scheduled. So we'll see how far we get. But before I start talking about health economics, let me say once again that I'm so happy to be here. I'm happy that you are here. It has been said already multiple times, please be interactive. By the way, does this work? Can you hear me? I know I have generally a weak voice, so if you don't hear me, just shout and I'll readjust things.
It's not very clear.
No?
It's not very clear.
All right. Does this work? Is this better? No. All right. Do you hear me better now? Yeah. I will try to keep it up a little bit, but I don't know how long I can last.
That mic was better, the previous one.
This one? This one?
Same. We'll increase the volume.
Oh, I see. Is this good? All right, I'll do my best. Oh. All right, 1, 2, 3, 1, 2, 3.
Yeah, good.
We'll make it work. Anyway, it has been said already multiple times, please be interactive, ask questions. If you, like this workshop is for you, it's not for me speaking here. It really is for you, so in order for you to get value out of this, ask questions. If there's something I say and it's not clear what I mean by that, it's not you, it's likely because I didn't explain it right. Again, ask questions. If there's something that you don't understand, chances are that there are other people in this room who don't understand what I meant by what I said. We're all smart here, so it's definitely not a mistake to ask if you didn't understand something. One thing that I also wanted to mention, I really liked what Dr. Tambu just mentioned, that there are certain interventions that may be important in Tamil Nadu and maybe not in Delhi. There's variation. There's variation across within this country. There's variation globally, even more so. And one thing that I would like you to keep in mind is that health economics applies locally. If you read a paper that doing an MRI scan for a certain condition is cost effective in Britain, it doesn't mean that it's cost effective here, or vice versa, because the costs are different. Outcomes will be likely similar, but may not. It really depends on the local conditions. But certainly prices vary substantially across countries. There's a huge opportunity. Even if you see a published paper that says this new vaccine or this new diagnostic test is or is not cost effective in the United States or in the UK or in Australia, that doesn't mean that you shouldn't do this study because it already has been done. The conclusion may not translate to India. So there's so many opportunities in this field. So the title of my first talk is Trial-Based versus Model-Based Economic Evaluation. And before I dive into that, I would like to briefly talk about terminology, because you will hear, especially me, using certain concepts interchangeably, but there are other terms that I understand a little bit differently. And the one is health economics. When we say health economics, from what I've understand so far, when we say health economics in India, it is an economic evaluation of interventions. That is exactly how people understand this term in Britain, perhaps even in Australia and countries of the former British Commonwealth. But in the United States, the term health economics is a lot more broad, because there are many other questions in healthcare that has to do something with economics, but does not really focus on evaluation of certain interventions. You can think of like, how should we pay physicians? Should we pay them for each additional service they provide, or should we implement some capitated-based payment schemes, for example? How should we organize healthcare? Should we have, what's the right ratio of physicians and nurses? Should there be some position in the middle between physicians and nurses? In the US, they have physician assistants, nurse practitioners. So those are questions that relate to healthcare, relate to economics. So they call them health economics, but it's not really about evaluation of interventions. So that's just like to explain why I will not be using the term health economics in this workshop. I will be mainly talking about cost effectiveness analysis, but it seems to me that that's how you understand health economics. So I just want everyone to be on the same page. I have a few other terms on the slide: economic evaluation in healthcare, health technology assessment, and cost effectiveness analysis. They all mean pretty much the same thing. So if you read a paper that talks about health technology assessment, it's a cost effectiveness analysis, likely. Cost utility analysis is a specific kind of cost effectiveness analysis where the effectiveness part is measured in QALYs, the quality adjusted life years. Sometimes DALYs, disability adjusted life years, but we'll talk about that later. So that's just to make sure that we're all on the same page. All right, so how should we even think about cost effectiveness analysis? It's a tool that is used for making decisions, making informed decisions, and hopefully making better decisions. Inherently, when we talk about making decisions, there must be some alternatives. If there's just one course of action, then there's not much to decide. So it's a tool to decide exactly as it has been already said, should we use this new treatment or that treatment? Should we provide vaccinations? Should we not? Should we make our roads better or not? Or should we implement, enforce using helmets or make our roads better? So cost effectiveness analysis is a tool to make decisions between alternatives. You can think, even if you don't immediately see what the alternative should be, there pretty much always is the alternative of not doing whatever you intend. For example, should we provide vaccinations or not? There's pretty much always an alternative. In many cases, there already is some standard of treatment and a new technology, new drug, new CT scanner, new treatment regimen. So this type of analysis can help us synthesize all the data that are very often measured in different units. You can think of a treatment that improves survival, but also alleviates pain, makes quality of life better. So all these different things that one treatment can lead to, can cause, and another one can maybe be better on the extending life, but maybe in poor quality. And so So what I'm trying to say is that this type of analysis helps us synthesize all the data into one tangible number that helps to make the decision. One thing that I would also like to stress out, cost-effectiveness analysis is a decision tool, but it is not the one and only decision tool. It provides some evidence, it synthesizes all the evidence we have into one number, but it doesn't mean that we have to make the decision based on that number. You should think of this analysis that it just like adds another piece of information, but it's not necessary, you don't have to always follow it. There can be good reasons not to follow the conclusion of this type of analysis. An example is that strictly technically speaking, it is cost effective in most countries to kill people when they're too old. Because when they're too old, they don't have much life to gain, and they cost a lot of money because they tend to be sick. Should we do that? Not really, right? So I know this is an extreme example, but the message usually comes across better in these extreme examples. So think of cost-effectiveness analysis as something that can help with a decision, but doesn't have to necessarily drive it. All right, I think I covered everything here. So the basic idea of cost-effectiveness analysis is pretty simple. The elementary idea is really, it's so simple, it's no rocket science. It will get complicated later, but the basic idea is to, you have two or more alternatives between which you're trying to decide. And you try to compare which alternative offers the best ratio of costs, incremental costs, and incremental effectiveness. So the idea is to find the total cost of each alternative, total effectiveness, and then calculate what we call an ICER, an incremental cost effectiveness ratio. And it's exactly what the name says. It's incremental cost effectiveness ratio. To be precise, I actually think it should be called a ratio of incremental cost and incremental effectiveness. As you can see, so it's a difference between cost of the two alternatives and a difference of effectiveness, and then you take a ratio. It will give you the additional amount of money that is needed to reach an additional unit of effectiveness in whatever units you decide to measure effectiveness. So to remember, it's an incremental measure. It's incremental relative to a reference, to an alternative. To decide what of the alternatives in the choice set should be the reference. That can be sometimes tricky, but usually it's not. Usually there is some established standard of treatment and there's a new technology. So usually when we do cost-effectiveness analyses, we calculate the ICER of the new technology relative to the standard of treatment. If your analysis is, should we do this intervention versus not, the not doing that intervention is usually the reference. Well, and then you calculate this number, and so what? So let's say it's 10,000 rupees per quality. Is that good? Is that bad? It depends. It depends on a so-called willingness to pay threshold, sometimes called cost-effectiveness threshold, which is something that the decision maker should decide in advance before you start doing this analysis. And in my own opinion, that's probably the weakest spot of this whole methodology. We will talk about that in greater detail later. But for now, let's just accept that the decision maker will tell you, this is my willingness to pay threshold. I'm willing to pay this much money for an additional unit of health. And that threshold should then drive the conclusion of the study. One thing that I also should have mentioned already. So, as I said, cost effectiveness analysis is a decision tool. It helps with the decisions. So who makes the decision? It can be a policymaker in the government. It can be a health insurance company. It can be, your own practice. So always keep in mind, if you were to do cost effectiveness analysis, who's the decision maker? Because you want to inform their decision. And certain decision makers are interested in certain costs, but they're not interested in other costs. Well, other decision makers may be. So the perspective of the analysis should be based on whose decision are we trying to inform. And that then drives what parameters should be part of the model. All right, let's talk a little bit about a so-called cost effectiveness plane. Very simple idea. It's a two-dimensional plane. One dimension is costs, the other one is utility or effectiveness. That's where we measure health gains. If you have two alternatives, one can be the reference, and then you can calculate the incremental cost, the additional cost it would take to do intervention A versus intervention B, or the reference. Same thing for effectiveness. If you find that, in this case, we find that our intervention of interest is more costly than the reference, but also brings in more utility, more effectiveness, gains more health. Is it worth it? That depends on the willingness to pay threshold. If you find that the intervention is here, what does that mean? It means that it's cheaper, but also doesn't get us as much health as the reference. Does this mean that we should not do that? It depends on the willingness to pay threshold. An example of this, in most cases, you will find that the new intervention is usually more costly and better. But in certain cases, it really can be here. If you think of, let's say there's a new vaccination for malaria, let's say. And the one that we have right now is pretty effective, but costs a certain amount of money. Let's say now we develop a new type of vaccine. It's substantially cheaper. It costs 10% of the original one. Has the same effectiveness, prevents as many cases as the original one, but also gives people a rash. No, it's not. So if you look at it from like the big picture, it's not as effective as the original one, because the original one saved people from getting malaria and didn't give them rash. While the new one gives them rash, but maybe that's a trade-off that we can be willing to make in order to save all this money, which then we can use elsewhere to gain more health. If the outcome turns out here, that's the ideal situation. It gains more health and it's cheaper. In this case, the incremental cost would be negative, while the incremental utility would be positive. So the ICER, the ratio would be negative. It's a negative number divided by a positive number. So if you see a negative ICER, it's really difficult to interpret it, so you don't really have to look at the actual number. if you see a negative sign, it means that one of the interventions is better and cheaper. And that's an easy decision. Let's do that. Same thing here, but the opposite idea. In this case, the new intervention is more expensive and worse. Why would we do that? Again, the decision is very easy. And again, in this case, the ICER would be negative. Because it's a negative, well, it's a positive number divided by a negative one. So again, if you see a negative incremental cost effectiveness ratio, it means that one of the two alternatives is better and cheaper, while the other one is worse and more expensive by definition. So you just have to look at the total costs and total effectiveness to look up which one is the dominant. I should say that. So if we're here, if the intervention is cheaper and better, we call it dominant. If it's worse and more expensive, we call it dominated. All right, now we're finally getting to trial-based evaluation. To do a health economics or cost-effectiveness analysis, you can do it either in a model. That means you sit by a computer, you find all the evidence in published literature, and then you do a model, and that's what we will be talking mainly about. But you can technically do a trial. You can randomize patients into groups and follow not only their effectiveness, which is what is usually done in randomized controlled trials, but you can also follow all the costs and record it on the way. When the trial is over, you can calculate the cost effectiveness in the incremental cost effectiveness ratio and do a cost effectiveness analysis along a fairly standard RCT. So it's an option. It's usually not, well, most published cost effectiveness analyses are model-based. So that's what we will be talking about. But I just wanted you to know that this is an option as well. So what would be the disadvantages of this? The main ones are that randomized control trials are usually very limited. The population that is studied is usually very handpicked. In many cases, at least in the United States, randomized control trials are usually done only on men, not on women. And but there are so many interventions that are suitable only for women, and then it's the conclusions may not be as valid. Second of all, study participants in randomized control trials are usually logged in very perfect conditions, but so the conclusions may not hold in the real world. Next one is that randomized control trials are usually limited in time. You just cannot have a randomized control trial that lasts years. It's usually very limited, maybe a couple months. So it's difficult to see what the costs and what the consequences on health would be in the long term. And finally, they're expensive. So it may not be cost effective to do a cost effectiveness analysis in a trial. All right, so now let's talk about model-based analysis. So what is a model in the first place? It's a simplified depiction of a real-world phenomenon designed to highlight key features, patterns, and/or relationships to gain insight into current and/or future experiences. So to develop a model, we need first to define what's the problem, what is the research question essentially? What are we trying to study? And identify the key features. So in a cost effectiveness analysis, it would be, so what is the disease? What are the possible outcomes? If we do this intervention, well, the person usually can, get healthy. That's what we want, or at least get better. But most interventions have side effects. Things can go wrong. So what can actually happen? Those are the key features of a model, of a typical model in health economics. An example of a model, not really in health economics. I don't know if you can see this. So here's a reality. This is a picture from Google Maps of Vellore. The main hospital is right here. But how do we get from the hospital to the fort? In reality, it would be really difficult to find a way. But in a map is an abstraction from reality, right? We took a step back, we got rid of all the noise that is not needed to find the way from here to the fort. And it's much easier to find your way on a map, in a model. Let's take a vote. So I have these two relationships, like these two data. Well, it's one data set visualized twice. There's no difference here. And now I will present two models. There's a simple line, and there's a curvy line. The two lines are models for the data, for the underlying data. Which model do you think is better? Do you think is this, so let's call this what's that, left-hand side, right-hand side. So who votes that left-hand side is better? Who votes that the right-hand side is better? It seems that this one is slightly winning, but it's not a clear cut. Well, the answer is it depends. It depends what you try to get. I would say that both of them describe the data pretty well, more or less. If you want to say a story, this model is very easy to interpret. As this variable goes up, this goes up. If you wanted to say that same story with this model, well, you would be like, well, it goes up and then it goes down and then it goes up. It would be difficult, right? If you want to get a prediction, maybe this model is better because it gets to the actual data points a little closer than this one. So it depends. And the point of this is when you build a cost-effectiveness analysis model, there's a certain art to it. You can include some outcomes that some people would be like, nah, is this really necessary? It just makes it more complicated. Or vice versa, you can make a very simple model and reviewers can say, well, this doesn't describe the reality very well. The situation is much more complicated. And then, it depends. To find the right balance between the model being simple enough, but describing the reality well enough, that's difficult. I won't lie to you. There are some recommendations, but also it's a very gray area. Two different analysts can build two different models for the same research question. And to figure out whether one is wrong or not, it's not always a clear cut. Sometimes yes, like some models are clearly wrong, but sometimes they're not. Right, we're getting close. So the main purpose of a model is to gain insight into what is happening in the real world. But we try to simplify it to be able to tell a story. If you think about it, like the best description of what is going on in this case are the individual data points. That is like what is actually happening. But we cannot really say much if we just list the data points. We need some model to help us gain insight and make a decision. Simplify the key patterns in the data to draw a reasonable conclusion. Transparency is critical. When you build a model, you really need to describe why you decided to either include this outcome or exclude another. When we will talk about critical appraisal of published studies, this is one of the key elements. It should always be described like, how did we come up with this model? Why did we include these specific outcomes, these specific treatment paths, and not other ones? Because if someone presents a black box to you, you like throw some number in this black box and another number will come out. Can you trust it? I wouldn't. Models can be helpful only if it's clear how you got to the specific structure, which then dictates what comes out of the model. And there's a good chance you've already heard this quote. It's pretty famous. All models are wrong, but some are useful. Neither of these models describes the data perfectly, but they can be useful in helping us tell a story. What's going on? Right, so in a typical model, in cost-effectiveness analysis, there has to be at least two alternatives, as I said before. If there's no alternative, why do an analysis at all? There can be 3, there can be 5, there can be 10 alternatives. That's fine. But there has to be at least 2. Usually each alternative can result in many possible outcomes. That's when this type of analysis comes in handy, because it synthesizes the evidence for things like, yes, if we do this particular intervention, some people will get healthy, some people will not. Some people will not get healthy and also have side effects. And maybe some people will die. So we try to synthesize all these potential outcomes into one number that will help us draw the conclusion. Each outcome usually occurs with some probability. That is a key feature of cost-effectiveness analysis models, is that they deal with uncertainty. If things were certain, it would be much easier to do this type of analysis, but they're not. We don't know who will get better and who will not, and who will suffer from side effects. But with the use of statistics and the probability theory, we can at least predict either the expected value for an individual or the proportion in a population that will get sick, get better, and so on. Well, each outcome is associated with some amount of costs and some amount of effects. Now I realize another thing that I should have mentioned. So when I talked about the perspective of the decision maker, whenever you see the word costs, always ask costs to whom? Because there can be, so let's say there's a surgical procedure. What are the costs to the patients? That's different from what is the costs to the healthcare sector. Like the hospital has to buy some machines, some tools, hire physicians, pay them salary, hire nurses, have beds, either heat the place up or cool it down, depending on where you are. So costs of certain procedures are different, depend on the perspective. So when you start the analysis, you first decide from what perspective you're doing the analysis, which then dictates, should we include the cost from the perspective of the healthcare sector, of the government, of the patients? It depends. But that is a key, that is a critical decision you have to make at the beginning of the analysis. Anyway, so going back, so each outcome is associated with some costs to someone and some effects also to someone. The effects can be measured in many different ways. We will talk about that later. In cost-effectiveness analysis, we have there can be many types of models, but the two main ones are decision tree models. That's something we will talk about today, and state transition models. That's something we will talk about tomorrow. The main difference is that decision tree models are just one period. People will get one period models. People will get to certain health outcomes and stay there, and that's it. Those models are very useful in modeling things with short time horizon, like a year or even shorter. But in reality, people can change from one health state to another. They can be healthy, then they get sick, then they get better, then they get worse again, and that's what state transition models are used for. So that's something we will talk about tomorrow. I actually think this is a good spot to take a break. So if you agree, let's do that, and we'll reconvene at 11. Question?
When you said it's important to assess who is paying,
yes.
Is it same as saying whose perspective it is, whether it's societal perspective or healthcare provider perspective or patient perspective?
So the question is if I should cite it, or...
So you said it's important to see who is actually making the payments.
Yes.
Who is talking about the
yes.
cost, who is incurring the cost. So
exactly.
Is it saying same thing as societal perspective and or healthcare provider perspective or patient perspective?
Pretty much. So let's say if we decided to do the analysis from healthcare sector perspective, we're interested in the costs to the healthcare sector, which can be the physician salaries, the cost of the machinery, all those amounts of money. Societal perspective takes one step back and looks at things from the broad societal perspective. In that case, we would include costs like if the patients have to contribute something to it, but also there are costs. For example, patients incur costs such as if they undergo a certain type of surgery, let's say. One has a fast recovery, the other one has a long recovery. The long recovery, that means that the patient is not productive. They're not making money, they cannot do work. That is cost to them. So we would include all these costs together. Maybe certain types of interventions mean that the patient is so incapacitated that they need a caregiver. And suddenly the caregiver cannot be productive in other way, cannot go to work. So those are all the costs that we would consider in a societal perspective type of analysis. But that's also something I will talk about later.
Thank you.
Great question.
Thank you.
So you spoke about the cost-effective, incremental cost-effective ratios, but by calculating that incremental cost-effective ratio, consider only cost in the cost involved and the effect. But wouldn't the ratio change with the period of time which is being considered for the intervention? Because sometimes the intervention could bring about an effect which will be incremental at the initial part, but later on might plateau. But the cost might continue to increase at the same pace, and then the ratio might actually vary.
Absolutely. You're exactly right. In each analysis, you usually decide on a time frame, time horizon. Some analyses consider just 1 year and consider only the costs and only the health effects that happen within 1 year. Then you calculate the cost effectiveness ratio for this 1 year time horizon. Whatever happens after 1 year, not a problem. Like that's not a problem of this analysis. But you have to be specific about this because whoever reads the manuscript then needs to know that, well, maybe the incremental cost effectiveness ratio is favorable within 1 year, but if the patients have complications 5 years down the road, it's not captured. This is certainly a limitation, but some analyses do consider a lifetime time horizons, and then they account for this. Yeah, so like you're exactly right. The cost effectiveness, the ICER would vary with different time frames. But again, that depends on the decision maker. What are they interested in? If they're interested only like, let's do this intervention for 1 year and we don't care what's going to happen after that, that's fine. But it has to be explicitly stated. Does that make sense?
The answer probably for that would be the state transition model.
Yes, yes. Those are usually much more appropriate for long-term analyses, because in the long run, people change health states. Yes.
How do you build in the value judgments or the utility part?
In the quality adjusted life years?
Yeah. Okay.
The quality is essentially a two-dimensional measure. It measures time and the quality at each moment within the time. But that's again something that we will talk in great detail in I think tomorrow, maybe actually even Thursday. But it has limitations. I'll be honest with you. It's not perfect.
In randomized trials, we talk of number needed to treat and number needed to harm. If there are net gains by an intervention, we say number needed to treat. And if there's serious adverse effects, we say number needed to harm. So do you have a similar concept when we talk of cost effectiveness? Because effect can go either way.
Yeah, essentially you incorporate this in the model, right? So at the beginning, you will start with a cohort of patients. And when I talked about all the different outcomes that can happen, is that some patients will get better. That will be essentially the positive type of the effect. But some patients will be harmed, and they have to be accounted for in the model structure. And depending on whether the net effect is positive or negative, that will be accounted for by the probabilities of getting harmed versus getting better. And so that is all accounted for in the model.
Thank you.
Right? Let's get it going. So we ended here. Let me now sort of go on a tangent and briefly talk about the expected value theory. I guess at least some of you already have heard of this, especially those of you in the biostatistics department. But this is a critical component of cost-effectiveness analyses. As I said, when we build a model in health economics, the model usually entails many outcomes. Each of them happens or is expected to happen with a certain probability. And to summarize all the different costs and all the different effects of each strategy, of each alternative, we use an expected value theory to do that. So just an example, we have two games here. We would flip a coin, so the chances are 50-50, that it would be either heads, the outcome would be either heads or tails. And in game one, if we play this game, you lose $1. If it's tails, you win 2. In game 2, if it's heads, you win $1. If it's tails, you lose $2. If you were free to choose, which game would you pick to play with me? 1 or 2? Why? Probability is 50%.
Chance of losing losing.
Exactly. So it seems that like the concept of expected value is somehow inherent here, right? To be to put this in technical terms, what we call an expected value is a probability weighted average. We look at all the outcomes, but we don't take a simple average, but we weigh each outcome with the probability of occurrence of that outcome, and we sum it all. So in this example, game 1 has an expected value of 0.5, positive 0.5. We would do it as, we multiply the outcome if it's heads, so 50% times -1, and 50%, we add 50% of the other outcome, that's positive 2. So when we do the math, we get positive 0.5. In game 2, the expected value would be negative 0.5. So on average, if we were to play this game multiple times, 100 times in a row, on average, if we play game number 1, you should leave with 50 cents in your pocket. If we play the game number 2, on average, or in the long run, you would leave with being 50 cents poorer. Important thing to notice here is that if we were to play whichever of these two games only once, let's take game number 1. If we played it only once, you will not leave with 50 cents. You will leave either with $2 in your pocket or $1 poorer. But in the long run, or in a population, if I play this game with every one of you, the average result will be positive 50 cents. So, going back to cost-effectiveness analysis, we're trying to make a decision that's very complex. There are many different outcomes. Each of them has some probability. And to be able to just make some sense out of all the different scenarios that can happen, we use the expected utility theory to bring all the cost of all the different outcomes and all the different utilities or effects into one number. For each strategy, we would have one expected cost and one number that will represent the expected utility, which then we can use in the calculation of the ICER, of the incremental cost-effectiveness ratio. So instead of the cost of before then I talked about just like cost and effects, but what we actually do, we plug in expected costs and expected effectiveness of each of the strategy. Does that make sense? More or less? All right, thank you.